endocrine pathology, multiple endocrine neoplasms, as well as pancreatic islet cell tumors with carcinoid tumors and Zollinger-Ellison syndrome. All right, so first and foremost, we're going to start off with the MEN syndromes, multiple endocrine neoplasms. This is very, very high yield and very important for your understanding, okay? So all MEN syndromes, these are autosomal dominant inheritance pattern, okay? So that's just like the first thing that you can think of. But once again, watch those Dirty Medicine videos to remember the inheritance patterns. There's like songs on them. Dirty Medicine literally made songs for each of the inheritance patterns, so watch those. They're very important. But anyway, starting off with MEN 1. Okay, when I see a patient, okay, they can have pituitary tumors, so like a prolactinoma or a GH pituitary tumor. Okay, so those are the two most common, but prolactinoma is the main common thing. That is a part of the MEN 1. Pancreatic endocrine tumors, all right, so like Zollinger-Ellison syndrome or anything that's involving the pancreas. And lastly, parathyroid adenomas, okay? And that's going to present with recurrent stones, all right? That's all associated with mutations of the MEN1 tumor suppressor gene, okay? Now, you might be wondering, what the hell does this mean? I have no idea what you're talking about. What is MEN? What is all this? Okay, all this is that these are multiple endocrine pathologies that present concurrently in the same person, okay, among generations as well. So in the same families as well as in the same people. And they seem unrelated, but we found the reason why they are related, why they present. These pathologies are presenting together in these patients. And it's because there's either mutation in the MEN1 gene, the MEN2A gene, and the MEN2B gene. So if there's a mutation in the MEN1 gene, which is a tumor suppressor gene, the patient's going to present with pituitary tumors. So like prolactinoma. And what's that normal presentation of prolactinoma? Well, they might have overall galactorrhea, right? Milk discharge from the nipples. They might have an overall decrease in ability for fertility. So they have decreased GnRH because of that increase in prolactin, right? They could have bilateral hemianopia because of that pituitary adenoma compressing on the optic chiasm. Okay, so those are the symptoms of pituitary tumor, which we already discussed earlier. Okay, but they also can present like not only with a prolactinoma, but they're also having issues with their pancreatic. They might have like some issues with the pancreas. So it could be Zollinger-Ellison syndrome, which we'll talk about later on. It could be a VIPoma, all right? It's rare, okay? These are rare. And then it also can present with parathyroid adenomas. And parathyroid adenomas just means that there's an increase in PTH. And an increase in PTH means that there's an increase in calcium. And so the normal presentation of these patients with parathyroid adenomas is recurrent kidney stones. So if you ever see recurrent kidney stones, that's a buzzword for parathyroid adenomas because there's increased calcium. That means increased calcium in the urine, not only in the body, but also in the urine because we have to flush it out, right? Because we're cleaning our blood. And that means that we can have an increased risk for kidney stones, calcium kidney stones. All right? So altogether, if I see recurrent kidney stones with maybe bilateral temporal hemianopia with like some galactorrhea maybe, and they have like ulcers in their duodenum, boom. That's MEN1. They're telling you about MEN1. And then not only that, they'll say like, oh, the mom has a history of recurrent kidney stones too. Okay, they're obviously telling you that there's some type of gene mutation within this family because it's autosomal dominant, and they're pointing at the MEN1 mutations, the MEN1 symptoms. Okay, so that's your first one, right? That's pituitary tumors, pancreatic issues, as well as parathyroid adenomas. Okay, MEN2A. MEN2A has parathyroid hyperplasia, okay? Once again, parathyroid hyperplasia, what is it going to present with? It's going to present with our recurrent kidney stones, okay? So there's some overlap between these men. Makes sense. That's why they all start with MEN, right? They're multiple endocrine neoplasms. So with MEN2A, the first one's parathyroid hyperplasia, okay? So if you see recurrent kidney stones, it could be either MEN1 or MEN2A. For MEN2A, the second one is medullary thyroid carcinoma. Medullary thyroid carcinoma, what they'll say, the presentation, is that, hey, this patient had increased levels of calcitonin. And then when they did like a thyroid examination and biopsy, they found amyloid. So they're hinting at, because remember, medullary thyroid carcinoma has a amorphous, feel or look to it because it is, as we talked about, amyloid deposits, and it secretes calcitonin. Okay? So that's the second one. The last one is a pheochromocytoma. That's going to secrete catecholamines. Okay, and that is a RET mutation as well. Okay, so for MEN2A, if I see like a pheochromocytoma with a parathyroid hyperplasia, so like if I see a patient that their mom or their dad has like recurrent and remitting like episodes of tachycardia and increased blood pressure and headaches, and then the child has recurrent kidney stones, All right. And then the dad also has like increased levels of calcitonin, and he had to get his thyroid removed ages ago because they found medullary thyroid carcinoma. That's MEN2A. All right. And the pheochromocytoma, what they really want you to know is that it's due to a RET mutation as well. Okay. RET, RET mutation. Lastly is MEN2B. MEN2B has the medullary thyroid carcinoma. It has the pheochromocytoma. Okay. So there has to be a differentiating factor. Mucosal neuromas. Mucosal neuromas, all right, it's in the name. They will literally just have like these oral, like on their tongue, they'll have like oral, like essentially ulcers, all right? And they also will look like patients that have Marfan's. So they'll be really, really tall and lanky, all right? Because they have this Marfanoid habitus is what they call it. So they have the body of a person that has Marfan's. So they call that Marfanoid habitus, okay? And that is also a RET gene mutation, mucosal neuromas. So then with MEN2B, the patient can present, hey, the dad has increased calcitonin levels with like amorphous material found. And so they removed his thyroid gland because they had medullary thyroid carcinoma. The mom has recurrent remitting, probably not the mom, but the dad also has recurrent remitting episodes of like headache and sweating. And the child is really, really tall, by the way. And he has these like tumors or these ulcers on his tongue. All right. And that's going to be, and the question they might ask, what is the ulcers on the tongue or the Marfan, the thing that's causing his tall body image? What's the mutation? And the tall body image is specifically the mucosal neuromas, and that's a RET gene. Okay. All right. So that's MEN1, MEN2A, and MEN2B. You have to know them. They're very high yield, very important. I hope I made it clear enough for you. So MEN1 is pituitary tumors, pancreatic endocrine tumors, and parathyroid adenomas. The patient's going to present with family history of those issues, and he himself has those issues, or she herself has those issues, okay? And that is, number one, pituitary tumors. They can have like the bitemporal hemianopia. They can have the galactorrhea, okay? Pancreatic endocrine tumors, they will present with recurrent like duodenal ulcers or small intestine ulcers. Parathyroid adenoma, recurrent kidney stones. Next is MEN2A, parathyroid hyperplasia, once again, recurrent kidney stones. Medullary thyroid carcinoma is the second one. You have increased calcitonin levels, as well as you have the amorphous material, okay, which is just amyloid. And then lastly is pheochromocytoma, which is a RET mutation, and they have that recurrent remitting or relapsing of the patient, like getting headaches, increased blood pressure, tachycardia, sweating, okay? And that's MEN2A. Lastly is MEN2B, medullary thyroid carcinoma, once again, same thing, increased calcitonin. Pheochromocytoma, same thing, relapsing, remitting with RET mutation. But the last one is mucosal neuromas from MEN2B, and that's going to be like oral ulcers or neuromas with a Marfanoid habitus. They're very tall, and that is also a RET mutation gene. All right? Cool. That's our MEN endocrine neoplasms. Honestly, I'm not going to do the pancreatic islet cell tumors and carcinoid tumor. I'll do that in the next video. But that is our MEN syndromes. You have to know them. Very important. The last thing I'll say, MEN1 is the only tumor suppressor. All right? MEN2A and MEN2B are RET mutations, and that means they are not tumor suppressors, but they are oncogenes. All right? And you'll learn about that later on. Remember, watch those videos. Listen to my pathology videos, but you'll learn about that later on. But understanding these MEN mutations and these MEN syndromes are so high yield, you're going to get all of them.